Good evening, all. So, today I'll be talking about clinical pharmacokinetics, that is, pharmacokinetics influencing the drug dosing regimens. The knowledge of pharmacokinetic principles is essentially deciding appropriate dosage regimens and modification of the dose in pediatric age group, elderly, pathological states like CHF, hepatic, and renal dysfunction. So let us discuss pharmacokinetics in children. A 2 months old infant is admitted to the NICU, neonatal intensive care unit. We take a case with suspected sepsis. The baby was born premature, 32 weeks gestation, and has history of jaundice. Standard dosing regimen for antibiotics often not appropriate for neonates due to immature organ systems. Which factors related to infant's age and development will you consider when selecting and calculating the safest and most effective dose of an antibiotic for this neonate? So just do brainstorming. Okay, let me discuss pharmacokinetics in children. Absorption. High density of skeletal muscle is there, richly supplied by capillaries. So IM injection is easy. Thinner stratum corneum is there and higher hydration of epidermis, allowing for topical drugs. And in infants, absorption is slow by GI due to decreased rate of gastric emptying. Rectal route provides good absorption for some drugs, example diazepam. And neonates have high percentage of body weight in form of water, that is 75% regarding distribution. So volume of distribution increases for water soluble drugs and loading doses are required for aminoglycosides. And neonates have low protein binding capacity, hence volume of distribution increases for digoxin, and there is decreased ability to metabolize drugs due to low plasma esterases activity. Succinylcholine has longer duration of action due to poor metabolism and phase 1 hydroxylation reaction in infants, and phase 2 enzymes they mature between 3 to 6 months. Glucuronide conjugation reaches optimum levels between 3 to 4 years of life. And regarding metabolism, there is immaturity of efflux transporters, reduced hepatic blood flow, thinner stratum corneum, and high hydration of epidermis, allowing for topical route of drugs. And renal excretory system matures over 1 year of age. Drugs excreted by the kidney are aminoglycosides, penicillins, diuretics, and they require reduced dose in neonates. This is the graph showing you absorption curves of IV, oral, and rectal. So you can see here IV is red line, most absorption is occurring, peak absorption, then concentration is falling. Oral route, there is a sloping curve, and rectal absorption is below IV and oral curve. No drug dosing in children. Drug dosing in children. This is given by the formula: dose is equal to adult dose into age over age plus 12, or dose is equal to adult dose into weight over 70. Approximate dose is equal to surface area of child meter square by 1.8 into adult dose. Then pharmacokinetics in elderly. Now take a case scenario: 82-year-old woman with history of atrial fibrillation and CKD, chronic kidney disease, is admitted for pneumonia. She has multiple medications on her current regimen. You plan to prescribe a new medication for pneumonia, but you're concerned about potential drug interactions and altered pharmacokinetics due to her age and existing medical conditions. How will you approach medication selection and dosing for this patient, considering her age-related changes in drug metabolism and potential for drug interactions with her existing medications? So just boggle your mind. What can be the pharmacokinetic factors which influence our age? What can be the possible drug interactions? So this chart I am showing you which is showing altered pharmacokinetics in the elderly, absorption, GI motility, strengthening blood flow, mucosal subsidy, and first form metabolism. All these factors decrease, affecting absorption. And distribution, body fat decreases, lean body mass, body water, body serum albumin, all are decreasing. Serum glycoprotein is rising. Then metabolism, hepatic blood flow decreases, liver mass decreases, phase 1 metabolism decrease. And in elimination, nephron size, renal blood flow, and GFR, enterohepatic blood flow decrease. So pharmacokinetic changes include reduction in renal and hepatic clearance and increase in volume of distribution of lipid-soluble drugs. There's increased sensitivity to anticoagulants, cardiovascular and psychotropic drugs, bioavailability of drugs undergoing first-pass metabolism, such as propranolol and labetalol, is increased. And pharmacokinetic changes include a reduction in renal and hepatic clearance. So water-soluble drugs tend to have small volume of distribution, resulting in high serum levels like gentamicin, digoxin, ethanol, theophylline, somatine. So loading dose of digoxin needs to be reduced by 20%. Lipid-soluble drugs have high volume of distribution, example diazepam, thiopental, lignocaine. And decrease in GFR has considerable impact on cardiac glycosides, antibiotics, and diuretics. ACE inhibitors like enalapril, perindopril, they undergo activation in the liver. So impaired role is there in severe hepatic failure and hepatic congestion. ACE inhibitors are excreted by renal route, so they need dose reduction. And all negative inotropic drugs, they need dose reduction in cardiac dysfunction in the elderly. Then drug therapy. To initiate drug therapy, clinician must select the appropriate route of administration, dosage, and dosing interval. Selection of a regimen depends on various patient and drug factors, including how rapidly the therapeutic levels of a drug must be achieved. Treatment consists of oral single dose of a drug, or continuous IV infusion, or in fixed dose at fixed time intervals. Drug is given IV or oral. Then parameters influencing dosing regimens. These are bioavailability, distribution, half-life, metabolism, and clearance. Bioavailability is the rate and extent to which drug reaches systemic circulation as intact drug after administration by any route. Oral bioavailability is given by the formula fraction absorbed into 1 minus extraction ratio. Extraction ratio is clearance amount of drug cleared of the plasma per unit time divided by hepatic blood flow. Now, what is the significance of bioavailability? It decides the route of administration. If bioavailability by oral route is low, it has to be given parentally, example lidocaine and nitroglycerin. Then variability in drug response, small difference in first pass metabolism leads to large changes in bioavailability. Then relationship between oral and IV dose. If bioavailability by oral route is low, it has to be given parenterally. Example lidocaine and phenytoin. Then small difference in first pass metabolism leads to large changes in viability. If oral dose is 20%, then 5 times IV dose has to be given only to get similar plasma levels, example propranolol. And onset of action, it decides drugs with fast viability, they are given in emergency when quick response is desired, example IV antibiotics. Now we come to distribution. Distribution is the amount of drug in the body, total amount of drug in the body divided by plasma concentration. And drugs get distributed to other tissues depending on factors like lipid solubility, ionization at physiological pH, presence of tissue-specific transporters, differences in regional blood flow, and extent of binding to plasma and tissue proteins. If a drug has large volume of distribution, for example chloroquine and digoxin, most of the drug that means is in the extraplasmic space, means out of blood vessels it is present and it is unavailable to the excretory organs. Now, body fluid of humans is distributed into three compartments: plasma, interstitial fluid, and intracellular fluid. Drug is distributed into three fluid compartments to varying extents. P-glycoprotein is expressed in liver, kidney, GIT, and blood-brain barrier. It removes the drugs absorbed in intestines back into gut lumen, removes drugs from kidney into urine, and from liver into bile. So any factor that increases the volume of distribution can increase the half-life and extend the duration of action of the drug. Then volume of distribution of many drugs is altered in various pathological states and pregnancy by altering the distribution of body water, by altering the permeability of membranes, binding proteins, altered accumulation of metabolites that displace drug from binding sites, example NSAIDs and anti-epileptics. In case of digoxin, volume of distribution doesn't change much in ascites because it has volume of distribution of 6 liters per kg. And pathological states like congestive heart failure, uremia, cirrhosis of liver can alter the volume of distribution. In pregnancy, total body water accumulates to 6.5 liters and there is fall in plasma albumin levels. So water-soluble drugs like beta-lactams and albumin-bound drugs like labetalol, levothyroxine are distributed widely. So the loading doses are required to achieve therapeutic drug concentration. And meningitis and encephalitis, they increase the permeability of blood-brain barrier and allow penicillin, which has normally poor penetration, to enter the brain. Then diseases like anemia, renal failure, chronic liver disease, they have low serum albumin levels. So there will be increase in free form of drugs, example oral anticoagulants, sulfonylureas, which are highly bound to plasma proteins. Digoxin is sequestrated in other tissues, may have distribution much more than total body water or even body mass. So digoxin is concentrated mostly in the heart, skeletal muscles, liver and kidney. Clinical significance of volume of distribution. It decides the dosage regimen. Loading dose is IV is equal to volume of distribution into target concentration. Oral dose is equal to volume of distribution into target concentration divided by bioavailability. It estimates the total amount of drug at a certain time present. It is helpful in hemodialysis in deciding whether the drug will be removed easily or with difficulty. Drug with small volume of distribution, hemodialysis will be useful. The speed at which loading dose is given depends on the therapeutic index of the drug. The loading dose is given slowly, example over 30 minutes for theophylline and over 24 hours for digoxin. Hemodialysis is useful in aspirin overdose and methanol poisoning because they have small volume of distribution. This is oral versus IV route of drug administration. IV bolus, the curve is falling after giving IV bolus dose. In oral, there is a rise in concentration of the drug and then it is falling after reaching the peak, shown depicted by blue line. Then we have a graph showing loading dose rapidly achieves a peak concentration so that the desired effect is achieved and maintained sooner. Suppose phenytoin, example phenytoin loading dose 15 mg per kg IV is given followed by 100 mg IV per oral 8 hourly. Amiodarone 150 mg IV over 10 minutes followed by 1 mg per minute over 6 hours. If the dosing interval is the same as the half-life of the drug, then maintenance dose should be half the loading dose, i.e. after one half-life of the drug concentration will have dropped to half, जैसे 100 से 50 हुआ, and after topping up with other maintenance dose will bring it back. Maintenance dose is half of 100, that is 50. It will bring it back to the same level. Peak concentration as a loading dose. Drug started with loading dose include digoxin, teicoplanin, voriconazole. A loading dose is most useful for drugs that are eliminated from the body relatively slowly, i.e. have long plasma half-life. Then we have graph of the steady state and therapeutic effects achieved much sooner with ethanol, NSAIDs, and meropenem with IV this loading dose followed by infusion. Whereas infusion without loading dose, the graph is slowly, the concentration of drug is slowly increasing, and with bolus dose only without infusion, the concentration is falling. Then maintenance dose in continuous infusion, your steady state concentration is directly proportional to infusion rate. When a drug is administered at constant rate, the plasma concentration of a drug rises and a state is achieved at which rate of administration is exactly equal to rate of elimination. This is called steady state plasma concentration. Example, heparin, insulin, pantoprazole, crystalloid infusions. With only maintenance dose without initial high dose, it would take a long time for the amount of drug to reach that level. Example, okay. Then we have maintenance dose and intermittent dosing. Here drug concentration achieves a steady state in steps, but end result is the same. With repeated administration at regular intervals, the plasma concentration oscillates about a mean. Using smaller doses at shorter intervals reduces the amplitude of fluctuations in drug concentration, but the magnitude of steady state concentration or the rate of achieving steady state is changed. This is important for drugs who have low therapeutic index such as digoxin or aminoglycosides, and that is why therapeutic drug monitoring is necessary. If the dose rate is changed, then a new average steady state is attained over the next 4 to 5 half-lives. Then we have graph of vancomycin comparing intermittent dosing with continuous infusion. Here, IV intermittent infusion is an infusion of volume of fluid or medication over a set period of time at prescribed intervals and then stopped until the next dose is required. Infusion is given either for 30 minutes or 60 minutes or 120 minutes. Targeted trough levels of 15 mg per liter and maintenance levels of 20 to 25 mg per liter. Continuous infusion has rapid target achievement and fewer subtherapeutic episodes compared to intermittent IV infusion. The continuous infusion is shown by dark line compared to intermittent IV infusion. Now let us discuss a role of liver. A 45-year-old woman with history of chronic hepatitis C presents with worsening jaundice and elevated liver enzymes consistent with hepatic decompensation. You plan to initiate empirical antibiotic therapy with ceftriaxone, but a Child-Pugh score indicates moderate liver enlargement. Impairment. How will you adjust the dosing regimen of ceftriaxone to account for an impaired liver function? If the normal dose is 2 grams per day and dose adjustment factor for class B is 50%, probably the answer is 1 gram per day. Then we discuss biotransformation. What is biotransformation? Hepatic clearance of drugs is divided into 3 groups. Flow-dependent drugs, capacity-limited binding sensitive drugs subdivided into capacity-limited binding insensitive drugs. Then we have intermediate extraction ratio drugs. Hepatic clearance depends on blood flow of highly extracted drugs. And congestive heart failure reduces hepatic blood flow and extraction ratio. Also in cirrhotic patients, dose reduction is needed for flow-dependent drugs. So as they are less removed from the blood and they may cause toxicity. Example, nitroglycerin, propranolol, lidocaine. Then sensitive to changes in plasma protein binding or free intrinsic clearance. Example, warfarin, phenytoin, quinidine we have. Then second group is only on intrinsic clearance they are depending. That is enzymatic capacity of the liver to metabolize drugs. Example, theophylline, antipyrine. And another group is hepatic clearance may be altered due to alterations in hepatic blood flow, plasma protein binding, and free intrinsic clearance. Example, aspirin, codeine, and quinidine. Then role of liver enzymes in metabolism. The cytochrome P450 system is a family of heme-containing enzymes found in liver and intestinal tract. Several enzymes also may be compromised to varying degrees by hepatic disease, producing considerable interpatient variability in drug response. Some drugs can induce or inhibit specific isoforms of the enzyme, affecting pharmacokinetic parameters of a drug. Rifampicin induces CYP3A4 isoenzyme, CYP2D6 induces metabolism of warfarin, isoniazid in chronic alcohol consumption, they induce CYP21 isoenzyme, which metabolizes drugs like acetaminophen, isoniazid, and chlorzoxetone. Ritonavir is a CYP3A4 inhibitor. It lowers the dose of other protease inhibitors. Erythromycin inhibits CYP3A4, increases theophylline, asmatazole, and terfenadine. Omeprazole inhibits CYP2C19, reduces plasma levels of activated clopidogrel. Cimetidine inhibits CYP50 enzymes, reduces hepatic blood flow, increases metabolism of theophylline, phenytoin, carbamazepine, and warfarin. Now let us take a case scenario. Based on these drug interactions, a 72-year-old man who had been taking rifampicin daily for several months was concurrently administered warfarin for thromboembolism daily for 10 weeks. During this period, the prothrombin time rose remarkably little as the dose of warfarin was increased. With difficulty, satisfactory anticoagulation was achieved by giving warf 20 mg daily. On discontinuation, of rifampicin therapy and subsequent stabilization of the thrombin time within therapeutic range required treatment with warfarin 7.5 mg daily. What's the possible drug interaction? You know it. So this is a Child-Pugh score based determining the severity of liver damage based on serum bilirubin, albumin, prothrombin time, then INR, ascites, and capillopathy. This is a scoring: class A 5 to 6 points, least severe disease; class B 7 to 9 points, moderately severe disease, liver disease; and class C 10 to 15 points, more severe liver disease. Then we have linear pharmacokinetics, first order kinetics. Metabolism follows either zero order or first order kinetics with drugs, and linear is rate of elimination is proportional to the amount of drug present. So dosage increases result in proportionate increase in plasma concentration, plasma drug levels. You can see here linear graph. The non-linear kinetics is rate of elimination is of a drug is constant regardless of the amount of drug present. Here dosage increases, saturates the binding sites and results in non-proportional increase in drug levels. Then there is Michaelis-Menten kinetics, which follows linear kinetics. Some drugs, they follow linear kinetics until the enzymes become saturated. The enzymes which are responsible for metabolism elimination, they become saturated, resulting in non-proportionate increase in drug levels. Here you can see the curve. First of all, it is linear, then it is bending. Now, what is half-life? This is the time required for serum plasma concentration to decrease by 1/2. 4 to 5 half-lives are required to reach steady state. Now we have significance of half-life. This is equal to 0.693 into volume of distribution by clearance. In dog toxicity, drug is removed if measures are taken within period of 4 to 5 half-lives, because after that 94 to 97% of the drug will be eliminated within 4 to 5 after 4 to 5 half-lives. And drugs with short half-life, they reach steady state rapidly, because the time required for to reach steady state depends on half-life. Drugs with long half-life take days to weeks to reach steady state. So we need loading dose of a drug or higher dose. In dog toxicities, drug is removed if that I have told. Then duration of action and dosing, half-life determines. If half-life is very short, few minutes, and example dopamine, sodium nitroside, then such drug has to be given continuously by IV infusion. And benzyl penicillin has half-life of 30 minutes but used 8 hourly in doses much higher than MIC due to its very high safety margins. Half-life is 12 to 24 hours. Once a day dose is sufficient, example doxycycline and clonazepam. And drugs whose half-life is more than 24 hours and administered daily, they accumulate on prolonged daily use and lead to toxicity depending on the therapeutic index. Digoxin is given, that is 5.25 milligram for 5 days. Then we come to clearance. The most important renal variable in drug elimination is glomerular filtration rate, and creatinine clearance is an indication of GFR. Dosage in patients with renal impairment is equal to average dose for a normal person into patients altered creatinine clearance per 100 ml per minute. Now here's a case scenario. The dose of entecavir is adjusted based on patient's renal status as determined by creatinine clearance. Like greater than equal to 52.5 milligram once a day, 30 to less than 50.25 milligram once a day, 10 to less than 30 to 0.15 milligram once a day. If creatinine clearance is 45.9 ml per minute and patient weighs 70 kgs, determine the dose of entecavir in microgram per kg. So this falls in the middle slot. So 0.25 milligram, this can be converted to micrograms per kg. Okay, divided by 70 kgs. So summarizing, the knowledge of pharmacokinetic principles is useful in adjusting dosages to optimize therapy for a given patient, and monitoring drug therapy and correlating it with clinical benefits provides another tool to individualize the therapy. So, thank you for patient listening. Have a nice time.